So good evening and a warm welcome to all the dignitaries present here. I'm Srivshi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with
Please
pride.
stop the background noise.
Okay, just a minute. Just a Ma'am, is it better now?
Yeah.
Okay, thank you. So it is with great pride that Planet serves as the digital partner for this event hosted by the Oncology Integrated Society, and the focus of today's session is recent advances in the management of early stage cancer cervix. So let's begin today's session, for which I would like to invite Dr. Dipti ma'am to take over. Ma'am, please proceed with the talk.
Okay, let us start with some lamp lighting and Ganesh Vanda if you have it.
Okay, yeah, just give me a minute, ma'am. Ma'am, is it okay if I play the Shashwati Vandana?
Yeah, anything.
Thank you, ma'am.
तो बोला कि आ जाओ घर आ जाओ 24 आ रहे हैं पेट में पानी भरा हुआ उसकी
Dr. A.K. Chaturvedi, background noise is being heard. Yes, please play Saraswati Vanda.
Okay, ma'am, I got the Ganesh Vandana, so I'm playing the Ganesh Vandana.
Okay.
Just give me a minute, ma'am. Just a minute. Okay, so thank you so much, everyone. And Dipti ma'am, you can proceed with the talk. Over to you, ma'am.
Okay, hello and welcome all to this yet another episode of Cancer Webinar Series under the aegis of Oncology Integrated Research Foundation, Dr. Chaturvedi Cancer Hospital, Gorakhpur, and the Clarinet team. Today we have with us the most dignified doctor of intense medical repute to chair the session, Dr. Saritha Shamsunder from Vardhaman Medical College, Delhi, who has a mind full of sound knowledge and magical fingers with superb gynecological skills, gynae oncological skills. Most humble welcome to you, ma'am. We also have with us, as always, the president of OIRF and the host, Dr. A.K. Chaturvedi, who is the man behind this webinar series and who is a renowned senior oncologist and owner of Dr. Chaturvedi Cancer Hospital with a record experience of treating cancer patients of about 40 years and who has been past president UPARI with extra trainings abroad and has many awards and publications to add to the extra feathers in his cap. Last but the most important, the speaker, Dr. Roli Purwar, a renowned gynae oncologist of our town, a lady known as the beauty with the brains, and who is very brilliant speaker of today's evening and who shall be talking on the recent advances on early management, early stage management of cancer cervix. Welcome, dear doctor. Once again, welcome all the dignitaries, participants, and speakers, chairpersons, all, one and all. Hope this webinar enlightens us and bridges all our lacunae of the knowledge at its best. Questions can be put in the chat box so that they will be dealt with at the end of the meet. Welcome all once again. Now I hand over my responsibility to Dr. A.K. Chaturvedi to conduct the further session. Dr. Chaturvedi, please introduce our chairperson, Dr. Saritha Shamsunder.
Thank you, Dr. Dipti. Today, we are holding this webinar about recent advances in the management of early stage cancer cervix. Now, cancer cervix is quite a common disease in females. It constitutes around 18.3% of all cancers in women. Mortality is quite high. It is 9.1% of all the cancers in females. It is 18% of per 100,000 population in females. 5-year prevalence rate is 42.8 per 100,000 population. Highest rate is found in Mizoram and lowest in Dibrugarh. Although the incidence varies from state to state, in UP it is around 22%, and in other places, as you know, highest I have already told, Mizoram states. 5-year overall survival rate is quite 46%, but it depends upon the stage of the disease. In stage 1, it is 98%, and as the stage increases, the 5-year survival rate keeps on going down. So treatment for the early stage cervical cancer depends on the patient's age, patient's tumor factor, as well as health system and what is available in the city. In the early stage, first we have to do the biopsy, bone biopsy, maybe leaf or surgery or radiotherapy, then treatment includes radiotherapy, chemotherapy, etc. So for discussing all these things in early stage cancer, we have invited Dr. Roli Purwar, and to chair the session, we are inviting Dr. Saritha Shamsunder, MD, FICOG, FRCOG. She is professor and unit head in Gyn Oncology, Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. Board member of International Federation of Colposcopy, Cervical Pathology, and organized Asia's first IFCPC World Congress of Colposcopic and Cervical Pathology in July 2021. She was chairperson in Oncology Committee, AOGD 23 and 25. She is still chairperson. Immediate past president, Indian Society of Colposcopy and Cervical Pathology, 2018 to 21. Member of Technical Expert Group of Cervical Cancer Screening Program of Government of MP, Punjab, Master Trainer, MP State Government Cervical Screening Program, Academic Coordinator, DNV Gyn Oncology Program at Safdarjung Hospital, Editor of Journal of Colposcopy and Lower Genital Tract Pathology. Award, she has got RCOG and JED Award for Academic Excellence, Aptaker Oration by Association of Medical Women in India. She authored 2 books and many chapters and articles in national and international journals. So I welcome Dr. Saritha Shamsunder. Kindly take the chair and conduct the proceedings.
Thank you so much, sir. Thank you, Dr. Dipti, for the kind invitation. It's a pleasure to be introducing Roli, who has been our student actually. She has done her post-graduation at Safdarjung Hospital, and she has done very well. And I've seen her, grow through these years. So, well, I know that she has done her PG at Safdarjung Hospital, her senior residency at AIMS, and then did a fellowship in Gyn Oncology at Banaras Hindu University. After that, I think I know she's done very well throughout. So over to Roli. Yes, so cervical cancer, early stage cervical cancer. We know about radical hysterectomy since many years. There have been many changes and a lot of new things are coming up about if we can go for any conservative surgery and then sentinel lymph node. And also there is a question of, about laparoscopic surgery. Niche in between laparoscopic surgery had taken up laparoscopic radical hysterectomy, but there is because of the evidence against recurrence and reduced survival in those having laparoscopy. So it's now no longer recommended. So it's open radical surgery for early stage cervical cancer. So let us hear more about all this from Roli.
Saritha ma'am, I'm very well known to Dr. Saritha. And she is my teacher from since I started my career as an obs and gynae, and he was my she was my best teacher, and I was very well connected to her in a unit, and she was my moderator also.
What a coincidence. Good. I chose her to be your chairperson. I was not knowing that. Continue, Roli.
Roli, put your video on.
Video is not visible. My PPT is visible, ma'am.
No, it's not.
My PPT is not visible.
No,
No.
My screen is not sharing.
nothing. If there is a problem, I think so we can share to the clarinet people, or you share through me. I'll transfer it to them. Hello. Where is Roli? Today we will be
Might
able
be
to
looking
hear us or not. I'm just wondering about the net problem.
She must be trying. She must be trying. There was some problem on the laptop.
In the net also there is a problem. Let's see what happens. She'll rejoin, I think so. Meanwhile, we can just discuss an outline about how we treat early stage cancer. Do you have to say anything? Few words? Dr. Saritha? Dr. Saritha? Are you online? I think so.
Yeah, sorry. Yeah.
No,
She
no
is there.
problem. Because Roli is not able to come online, let us ourselves discuss an outline or the early stage, how we managing the early stage of
You
cancer
want,
cervix.
I have
An
a
outline.
presentation on it if you want, I can.
Okay, sure. Our pleasure
Okay.
and our honor if you just
Okay.
release it on air. It'll be really
One
good.
second. Let me just open it. Hold it.
At times it happens.
I know. Okay, so can you see?
Sure, so nice.
Yeah.
So nice of you. Thank you so much. Surgical management of cancer cervix.
Very
Cervical
nice.
cancer. Mm.
Okay, so just let me go over briefly and then Roli can add on.
Mhm.
So a little bit about the history of surgery for cervical cancer. What are the principles of surgery for cervical cancer and what are the types of hysterectomy? What are the complications and what are the new developments? So if you look at the history of surgery for cervical cancer, initially what they used to do is cervical amputation of prolapsed uterus. And then when Osiander did cervical amputation of a normally positioned uterus. And then they went on to doing total abdominal hysterectomy. And it was from in 1878 who actually described extended hysterectomy with lymphadenectomy also, because otherwise the survival was very poor. And then Journey also did vaginal hysterectomy for cancer cervix. So, but it was Ernst Wertheim who actually started a new chapter in the surgical treatment for cervical cancer, because he did 500 cases of transabdominal extended hysterectomy in 1911 and showed that that is what is going to improve the survival, and that is why the Wertheim's hysterectomy is known as the standard radical hysterectomy in Western countries. At the same time, Shorter described radical. And a little later, he actually described the radical vaginal hysterectomy. So it was because of this discovery or sort of invention in the surgery for cervical cancer that Wertheim's hysterectomy became the standard treatment for surgical treatment for cancer cervix. And then later on there were developments. There were two doctors, Latsko and Okabayashi, who believed that they were both Japanese, who believed that the Wertheim's operation was not radical enough for the treatment of invasive cancers. And then he also described the space that we know of, the pararectal space and the concept of three ligamentous structures. And Okabayashi described the medial pararectal space. So he described opening the spaces and also the concept of the ligamentous structures. And they in fact describe that it is because of these spaces and the ligaments that have to be ligated when at the time of doing a radical hysterectomy. So, and then there is an Indian contribution also to the radical hysterectomy, the development of radical hysterectomy, and that is Dr. Subodh Mitra from RG Kar. So the famous RG Kar Medical College is also famous for Dr. Subodh Mitra, and who actually set up the CNC, the Cancer Institute, the Chittaranjan National Cancer Institute in Kolkata, and he developed the radical vaginal hysterectomy with extraperitoneal pelvic lymphadenectomy, and that is called the Mitra's operation for cancer cervix. So now later, we have it was so this is basically this will summarize the development that was Wertheim's, and then the Latchko and Okabayashi, and then later on, no, surgery was not always safe because of the antibiotics, and there was a lot of infection, and gradually radiotherapy was replacing surgery as the first line therapy. But then it was the revival of this, who revived. So it was revived by Joe Meeks in 1954 in USA. So he revived the radical hysterectomy with pelvic lymphadenectomy. And in fact, he described the 3D concept of the radical hysterectomy. So we have, so if you history wise we can go that the first one was the Vadaim cystectomy, then there's Lachko and Okabayashi from Japan, and then we have the re-evaluation of Vadaim cystectomy by Bonney, and then the Joe Meeks was the one who revived the radical hysterectomy, and then Dargent was the one who described radical trachelectomy, so that is the radical excision of the cervix. And then there were also the Hockel described mesometrial resection on radical hysterectomy, and there was also a development of laterally extended parametrectomy in cases where they are inoperable. I mean, where there is a spread to the parametrum. So basically, how is cervical cancer managed? Surgical for stage 1 and stage 2A1, and chemoradiotherapy is for stage 2A2 and 2A2B, 2 and stage 3 and 4. Now, what are the types of surgery? So we know about all this, the staging of cervical cancer, stage 1, when it is 1A, when it is limited to the cervix, and 1A when it is only microscopic, and 1B when you have a macroscopic lesion on the cervix, and depending on the size, if it's less than 2 to 4 and more than 4, that's how you describe the stage. And then you have 2A1 and 2A2. So surgery is possible only in the early stages up to 2A1. So these are the changes in the FIGO staging that was in 2021. These things were added. There was no longer a horizontal spread, and then also there was addition of the third. The stage 1B was divided into B1, B2, and B3. And then there was this addition of 3C when there was involvement of pelvic and paraaortic lymph nodes. So basically, when you do surgery for cancer cervix, you need to remove the tumor, a good margin of healthy tissue, and the draining lymph nodes. So the different types of hysterectomy, type 1 is a simple extrafacial, type B is a simple simple total hysterectomy or a semi-radical hysterectomy, and type C1 is a radical hysterectomy with nerve sparing, because normally when you take out the ligaments, there is the nerves are also in the ligaments, and then they can be involved, and that can lead to bladder dysfunction. When C2 is when there is when you go laterally up to the pelvic wall, and D1 and D2 they are laterally extended parametric. So the types of radical hysterectomy are classified they were classified by Piver and Rutledge as type 1, type 2, and type 3. And Querlo and Morrow later described them as type A, type B, and type C, where type A is basically it's an extrafacial hysterectomy, whereas a type B or a type 2 hysterectomy is when you take out the parametrum is at the level of the ureters, and you take 1 to 2 centimeters of the vaginal margin. And this is indicated for type 1A1 with LVSI or 1A2. And type C radical hysterectomy is for stage 1B1, B2, and selected cases of stage 2A. So here uterus and cervix and upper 1/3 of 1/4 or 1/3 of the vagina is removed, and the ureters and you go through the cardinal ligaments are divided at the pelvic side walls, and the uterosacral ligaments near the sacral origin. And the bladder is mobilized up to the middle vagina, and the rectum is mobilized below the cervix. So it's mainly the laparotomy approach. So basically, if you're looking at the cutting line, this is the cutting line of total simple hysterectomy, and this is of the radical hysterectomy. Anyway,
Have a glass of water, ma'am.
yeah, 1 second.
Having a sore throat, I suppose.
So these are the different supporting tissues we need to address when you're going for a radical hysterectomy, because since you have to remove not just the cervix but the vagina also, so you have the vesicouterine ligaments, and you have to open the vesicouterine ligaments, divide them, and push the bladder really down. And laterally you have the cardinal ligaments, and you have the ureter. Sorry about this. So laterally, you have these cardinal ligaments, and you have to actually, when you're doing a type C2 radical hysterectomy, you have to go right up to the pelvic wall. So which means that you have the ureter here, the ureter runs in the cardinal ligament. So that has to be mobilized laterally so that you can take this manometry. And also the pararectal space, I mean, the uterosacral ligaments have to be ligated here. So therefore, again, you need to mobilize the rectum, open the rectovaginal space, and separate the rectum from the vaginal wall. So therefore, it is important to identify and open these spaces, which are basically nothing but loose areola connective tissue. And these spaces have to be opened carefully for lymphadenectomy and also for separating these ligaments, which can be divided. So that is what I was saying. This is the cutting line of the simple hysterectomy. This is the type B hysterectomy, and type C is going straight up to the pelvic wall. And that's the resection line of the radical hysterectomy on the ventral side. You take you're taking the parametrium also, the cardinal ligaments, and also you're taking the upper 1/3 of the vagina. And here posteriorly, you can see the uterosacral ligaments also. Now, Jomi was the one who described a new system of classification for radical hysterectomy. So not only all that, he also described removal of the space, and he described division of the paracervix and the parametrium, and also the deroofing of the ureters. So that's summarizing the treatment. It is for stage 1A, which is microinvasive carcinoma. You can also go for a conization. So conization is the treatment of Joyce if the margins are negative and she's medically inoperable. You can just keep her under follow-up. But if the margins are negative and if they're medically operable, you can actually go for an extrafacial hysterectomy. But in a patient who's young and needs fertility sparing, and for fertility sparing, conization is the treatment of choice. On conization, if you find positive margins and she's medically operable, you can go for hysterectomy or re-excision. But if it's positive for malignancy, that one needs to go for a radical hysterectomy with pelvic lymph node dissection. If she is medically inoperable, then go for radiotherapy. Now, stage 1, because 1A1, when there is LVSI, and stage 1A2, there is a risk of lymph node metastasis. So radical hysterectomy with pelvic lymph node dissection or a radical trachelectomy can be done. For stage 1B1 and stage 2A1, it's a type C radical hysterectomy with pelvic lymph node dissection. This is preferred in young patients because there is no radiation damage, and also they can conserve the ovarian function. The other alternative is chemoradiotherapy. For stage 1B2 and 2A1, surgery or radiotherapy can be chosen as the primary treatment. Both have similar outcomes, but the advantages with surgery are you can determine the postoperative stage precisely on the basis of histological findings and treat cancers that are likely to be resistant to radiotherapy. And you can conserve ovarian function by intraoperatively, you can go for transposition of the ovaries. And so type C radical hysterectomy is the standard procedure along with pelvic lymphadenectomy. So I think maybe I can stop here. Then Roli, are you able to open your presentation?
Yes, ma'am, I'm there.
Okay. Then I'll stop here and you can carry on.
Thank you, ma'am.
Thank you, ma'am, so much for wonderfully replacing Roli for a short time.
Yeah, so it's just covering the principles and the basics of surgery.
You have
No,
presented it
it's
so
very
well,
nice.
Thank you, thank you.
Very nice
informative
presented.
and crisp. Really, it's giving a lot of knowledge. And of course, it shows that you can do both radiotherapy and surgery both in
Yes,
an early stage.
yes,
Depends. If the staging
yes,
is done properly by general non-oncology doctors, mostly there is a problem. And many times people come with us patients, they say the doctor didn't say for radiotherapy. Maybe the stage was wrong
Mm.
when
And
they
in fact, the
Yes.
role of pathologist is very important in this
Ah,
stage. If he is not able to tell it whether it is 1A or 1B or even 2A, then everything is gone in vain. So we have to take a safer margin towards the radiation. Otherwise, if it is truly 1A or 1B1, you can go ahead with surgery without any problem.
Yes, true.
especially
Also,
if
it's
it's
a
a younger patient and fertility preservation. For that, it's good.
Yeah,
And
conization.
if it is an old patient after postmenopause and all that, then I think so radical hysterectomy can be done or radiotherapy. Depends on what the patient wants.
yeah,
Role
also
depends.
it's also
What about
assessment of the
Dr. Roli?
stage. Assessment of the
Yeah,
stage is
that's
also
very
very
important.
important
In fact,
because yeah,
everything depends upon, yeah,
Upper
everything
staging.
depends upon assessment of stage. Okay, go ahead. Ravi.
so one is clinical staging and then imaging. Now, imaging also has to be done accurately and it has to be reported properly. So it's not just getting an MRI, also reporting the MRI is also it's
Yeah,
important because otherwise you can get it all wrong.
Yes,
absolutely. Right.
that's right.
Ma'am, I'm sharing my screen. Is it visible? My PPT is visible?
Yes, we can see.
It is visible,
Just
ma'am.
put it on
Please make
slideshow.
yes, make
Yeah.
it full screen.
Thank you. Thank you all for welcoming me in this session. And I'm presenting recent advances in the management of early stage cancer cervix. As we all know that cancer cervix is the second most common cancer in the India and is the leading cause of death. It is the fourth most common cancer worldwide with an incidence of around 6 lakh per year in India overall and with 1,27,000 in India with a mortality rate of around 80,000 per year. As we can, due to high screening facilities available in developed countries, high proportion of cancer cervix cases are diagnosed in early stages. By early stage cervical cancer, I mean from FIGO 2009 staging, stage 1A1 up to 2A1. FIGO 2009 staging is I am taking because there are certain trials which were retrospectively and prospectively were done from 2010 to 2020, and they have taken FIGO 2009 staging, and so I am taking FIGO 2009 staging for Abhi currently. If the fertility the standard of care, if the fertility preservation is not required, then radical hysterectomy with bilateral pelvic lymph node assessment was done. As FIGO 2009 staging I'm showing here, in the difference between FIGO 2009 and FIGO 2018 staging is that in FIGO 2018 staging, there is the transverse, in stage 1, the transverse dimensions were excluded, only depth of invasion is taken, nodal status has been taken, and imaging has been also added in 2018 staging. Previously, in 1980s, it was Piver and Rulch types of hysterectomies were defined, but currently Quidlo-Moro classification we are using, and there are 3 types of hysterectomy: type A, type B, and type C. In type A hysterectomy, that is extrafacial hysterectomy, it is recommended for stage 1A1. Type B is divided in type B1 and type B2. Type B hysterectomy is done for stage 1A1 with LVSI and stage 1A2 cancers. And type C1 radical hysterectomy is done for local disease without obvious metastasis, including stage 1B1 to 1B2 and selected stages 1B3 and 2A1. The main difference between modified radical and radical hysterectomy is that the paracervix is resected at the level of ureter bed in type B, and in type C, it is up to the pelvic side wall. We resect the parametria, and type C is divided into C1 and C2. With C1 is the nerve preserving, in which the autonomic nerve plexus is preserved. When we come to early stage cervical cancer, gradually there is a gradually when we review the literature, there is de-escalation of the procedures. Like in 1980s, we were doing class 3, and then we were shifted to class 2 pivot hysterectomies. In the last 2 decades, it was shifted to type B and type C1, Kurlo-Moro classification. And recently, there are certain trials which are showing fertility preserving surgeries and less radical surgeries for type 1 in early stages of cervical cancer. Coming to the review of literature, there is when we are talking about the management of early stage cervical cancer, there were certain before 2021, there were only retrospective studies and their systematic review were there. So there was one systematic review that was done in 2011, which included 5 retrospective studies in which the sample size around 1100, and they have shown that in early stage cervical cancer, there is around less than 1% of parametrial involvement is there. So there is not much need for going excessive radical resection in these cases. Similar to that, there is another trial that is published in 2014 in Gynecological Oncology by Ramirez et al. And it also showed that in radical surgery can replace simple hysterectomy procedures in early stage cervical cancer. There is another trial published in Medical Journal of Obstetrics and Gynecology in April 21. There were 21, it is a systematic review of 21 studies, but there was simple hysterectomy was compared with radical hysterectomy. There were many variables, but the raised concern was that for stage 1B1 disease, there was death rate was higher, 5.8% with simple hysterectomy procedures. But the quality of studies were variable, which limited the conclusion. This is the first landmark trial that is done by Landini et al. That is published in 2011. It is a first prospective study that was done to differentiate between class 1 versus class 3 radical hysterectomy in stage 1B1 2A cervical cancer. The Landini et al. It took he took 125 patients in FIGO stage 1B1 2A. He took tumor size in which the tumor size is less than 4 centimeter. At that time, the study was done between 1980 to 1987. Piver class 1 hysterectomy was done in 62 cases, and Piver class 3 hysterectomy was done in 63 cases. The overall survival, when we come to see the overall survival, it was a long 15-year follow-up study. After 15 years, the overall, there was no difference in overall survival between class 1 and class 3 radical hysterectomy. The p-value is 0.11. And especially when the tumor size is less than 3 centimeter, the overall survival was 76% for class 1 and 80% class 3, which is almost similar with p-value of 0.88. And he also found that there was increased morbidity in class 3 radical hysterectomy with grade 2 to 3 complications. And almost double, that is 45% of patients were complicated with simple hysterectomy, and 84% of patients were getting complicated with type 3 radical hysterectomies. But the only limiting factor in this study was that he took adjuvant RT, that is at 69% in class 1 and 55% in class 3 radical hysterectomy. So now, why are we considering less radical surgery? The two major factors for considering less radical surgery is that we have already seen that in early cancers, there is less than 1% chances of parametrial invasion. And in low risk tumors like lesion less than 2 centimeter, as FIGO 2018 has divided FIGO 1B, 1B2, 1B3 according to the size of the tumor. So lesion less than 2 centimeter, depth of invasion less than 1 centimeter with negative nodes, negative cone margins, negative imaging for metastatic disease, and no invasion of the lymphovascular space. First thing. And next point is that when we go for radical surgery, there is increased morbidity associated with that, like urological like urological, sexual dysfunctions, GI complaints, because we disturb autonomic plexus. So this is the SHAPE trial that is published in 2024 in NEJM. It is the first randomized controlled trial that is done between simple versus radical hysterectomy in women with low risk cervical cancer. It is the largest trial till date which has done till now. It is a phase 3 multicentric randomized trial and non-inferiority trial comparing radical, showing the hypothesis was that simple hysterectomy was non-inferior to radical hysterectomy in early stage of cervical cancer. The objective of the study was that simple hysterectomy will be associated with similar efficacy and less surgical morbidity compared to radical hysterectomy in patients with low risk early stage cervical cancer. The primary outcome that was taken initially, that was pelvic recurrence free survival, but since during the follow up of their 700 cases, there were very less pelvic recurrences. The survival rate was very high, so they changed the outcome to pelvic recurrence. The secondary outcome was pelvic recurrence free survival, extra pelvic recurrence free survival, overall survival, sentinel node detection, parametrial involvement, adverse events, and quality of life. It was a 1:1 multi-center prospective trial. 700 patients were recruited. The trial was done in Western European countries, in which 12 countries were included. The trial was done between December 2012 to November 2019. The power of the study was 85% with non-inferiority on the basis of margin of 4 percentage point at a significance level of 0.05. Inclusion criteria: all squamous, adenocarcinoma, adenosquamous were included. Rare carcinomas were excluded. FIGO 2009 stage 1A, 2 or 1B1 were included, in which less than 2 centimeter depth of invasion should be less than 10 mm on bone margin, less than 50% of cervical stromal tissue on MRI, and no evidence of lymph node mets, and MRI was mandatory. The important point is that LVSI was not an exclusion criteria. Exclusion criteria are other histological types: stage 1A1, lesion measuring more than 2 centimeter, pregnancy, neoadjuvant chemotherapy, desire to preserve fertility. The trial scheme was that the patient were randomized into 1:1. Arm 1 is control arm, that is radical hysterectomy arm, and experimental arm was simple hysterectomy arm. And the primary objective is to follow the pelvic recurrence at 3 years. Regardless of treatment assignment, pelvic lymph node dissection was done in both groups and with optional sentinel lymph node mapping. The surgical procedure was simple hysterectomy versus radical hysterectomy. In both the groups, sentinel lymph node biopsy was optional, but bilateral pelvic lymph node dissection was done in both groups. The important point is that the mode of surgery was at surgeon's discretion. If the patient is randomized to simple hysterectomy group, if the surgeon at the time of OT, if he think I can change the tumor, I can change the type of surgery, he can change. So there is one table in which it has shown that per that intention to treat population, they have 350 were taken. But later, the surgeon has switched 7 patients of simple hysterectomy were switched over to radical hysterectomy, and 2 patients of simple hysterectomy were switched over to radical. So total per protocol population was 317 in simple SH group, and in radical hysterectomy there were 312 patients. Kaplan where curves are made. I'm coming to results. The baseline characteristic, the important point is that all 75% of the population was white. Only 6% of the population was Asian population, with 77% of the patients were in age group less than 50 years. Most of the cancers were squamous cell carcinoma of around 62%. The most common tumor FIGO staging was 1B1. Most common grade was grade 2. And the diagnostic procedure before going for hysterectomy is the most common was conization, done in 84% of patients. Surgical approach, in most of the cases, the surgical approach was laparoscopic or minimally invasive, because at the time of recruitment of this study, the LACC trial was not done, and the results of LACC trial were not open. When they are doing the analysis, the LACC trial came. The post-surgical findings, the positive notes on final pathology specimen was 3.3% simple hysterectomy group and in 4% in radical hysterectomy group. Then coming to primary outcome, when we go for when we go to see pelvic recurrence, we have seen that in 3-year pelvic recurrence, between simple hysterectomy and radical hysterectomy, the hazard ratio was more than 1. It is the hazard ratio, that hazard ratio came out to be 1.12. So it is showing that is simple hysterectomy is definitely non-inferior to radical hysterectomy. In intention to treat analysis, and they also done per protocol analysis, there is also hazard ratio is 1.01. So there is one thing is important, that the death from cervical cancer was in 4 cases in simple hysterectomy and 1 case in radical hysterectomy. These are the secondary endpoints. When we go to secondary endpoints, when we go for overall survival, this is 99.1% simple hysterectomy cases and 99.4% radical hysterectomy cases in 3 years, and the hazard ratio is 1.09, which is also showing non-inferiority. As I already told, most common surgical route is MIS. The results of this study is published, shown in ESCO meeting 2023, and and according to their result, it was proven that simple hysterectomy is non-inferior to radical hysterectomy. When we go for safety outcome, that is, we are planning for for early stage cervical cancer, the urinary complications were very, very less in simple hysterectomy than radical hysterectomy, and it is statistically significant. When we go to patient reported outcome, that is quality of life and sexual health, there were significant differences were seen between the 2 groups over the time, and all were in favor of the simple hysterectomy group. So in early stage low risk cervical cancer, pelvic recurrence rate at 3 years with simple hysterectomy was not inferior to radical hysterectomy. There are fewer urological complications following simple hysterectomy. There is better quality of life, and sexual health measures were seen. Results are in line with those of CONCURVE trial, which I am discussing further. Adenocarcinoma grade 3 and LVSI positivity, it is an exclusion criteria in CONCURVE trial, which I am going to discuss further. This SHAPE trial is not designed to assess the safety of MIS in low risk early stage cervical cancer. The strength of the study, it is multi-centered. It is multi-centered randomized controlled trial with minimal bias, and it has included both patient quality of life and sexual outcome data. And rate of adjuvant treatment received in both groups are almost equal. The limitations of this study is that there were very small number of events, that at the time of final analysis, they have changed their primary outcome. Very less population from developing nation, largely it is in Western Europe, Canada. Median follow-up was 4.5 years, and recurrence beyond this time frame is not possible. Coming to other trial, that is CONCURVE trial and lesser trial, and there is one also ongoing trial, GOG 278 trial. In a CONCURVE trial, it is a single arm prospective trial that is published in 2021. It evaluated conservative surgery in participants from 16 sites in 9 countries. It is a US based trial done in the Mac Anderson Cancer Center in USA. It is done between April 2010 to March 2019. And it took squamous cell carcinoma any grade and adenocarcinoma grade 1 or 2, tumor size less than 2 centimeter by physical examination, no LVSI. The important is that no LVSI, negative imaging for metastatic disease. The last 2 criteria, depth of invasion and conization margins and endocervical curettage, were negative for malignancy. This was taken after they have seen their first pelvic recurrence as soon as the trial has started in 2010. So they added more 2 criteria. They took 100 evaluable patients of stage 1A2 to 1B1. The procedure done was conization if the patient desires fertility preservation. If the patient do not desire fertility preservation, they did simple hysterectomy. Sentinel lymph node biopsy versus bilateral pelvic lymph node dissection were done. And there was third group also made, that was inadvertent post-op diagnosis, that if the patient come with a history of hysterectomy, simple hysterectomy, and it came out to be a CS cervix, and if it is a stage 1A2 to 1B1, it was included in the study. Median follow-up was 36 months. The mode of surgery most common was minimally invasive, and they see recurrent disease. There were 3 patients within 2 years of surgery. In simple hysterectomy, With lymph node dissection, there was no recurrence. In inadvertent simple hysterectomy followed by lymph node dissection, there were 2 recurrences. And in conization plus lymph node dissection, there was 1 recurrence. So the highlight of the study was that the rate of positive lymph node was 5%. Rate of residual disease in the hysterectomy specimen following conization was 2.5%. The 2-year recurrence rate was 3.5% overall. The limitation of the study is a prolonged study period of almost 9 years. Inclusion criteria were amended during the course of the trial, and the study was stopped in 2016 because of 3 recurrences. And it is restarted after excluding women with inadvertent diagnosis. So the conclusion of the study was that conservative surgery with conization and simple hysterectomy is feasible in patients with early stage low risk cervical carcinoma. The third trial, that is a lesser trial, it is a randomized phase 2 non-inferiority trial. It is done in Northeast Brazil between 2015 to 2018. And it included only 40 patients with 20 patients of simple hysterectomy and 20 patients with modified radical hysterectomy with bilateral pelvic lymph node dissection. 52 months of follow-up was done. The overall survival was, there is no statistical difference between overall survival and disease-free survival. The morbidity rate was 15% simple hysterectomy group and 25% modified radical hysterectomy group. The limitation of the study, small sample size, low risk criteria was not followed strictly. LVSI and depth of stromal invasion not considered. Despite this, there is very low recurrence rate, 2.5%. And then there's another GOG 278 ongoing trial, it is going on, and it will add on further and give evidences for early stage cervical cancer. It is a phase 1-2 multi-center prospective cohort study, and it is comparing simple hysterectomy or conization and pelvic lymphadenectomy. And it is basically done to see the physical function and quality of life of the patients. Now coming to the latest NCCN guidelines version 2 that were latestly updated after these trials. They are saying that in stage 1A2, 1B1 cervical carcinomas that are diagnosed based on cone biopsy, and all conservative surgery criteria must be met, like no LVSI, negative cone margins, squamous cell or usual type adenocarcinomas, tumor size less than 2 cm, depth of invasion less than 10 mm, negative imaging for metastatic disease. We can go for extrafacial hysterectomy plus pelvic lymphadenectomy or sentinel lymph node mapping if the patient doesn't desires fertility. But if there is LVSI is there, then we have to go for modified radical hysterectomy plus pelvic lymphadenectomy or pelvic EBRT plus brachytherapy. If the patient desires fertility sparing procedure, then we can say, then with these criteria met, if low risk criteria are met, then we can go for cone biopsy with negative margins plus pelvic lymphadenectomy or sentinel lymph node mapping. If incidental finding of invasive carcinoma after simple hysterectomy, then pelvic lymphadenectomy should be preferred, or we can go for pelvic EBRT plus brachytherapy. If nodes negative, then surveillance, then patient can be put on surveillance, or if positive nodes are present, then we have to give an adjuvant treatment. To conclude my session, following adequate or rigorous preoperative assessment, simple hysterectomy can now be considered the new standard of care for patients with low risk early stage cervical cancer, supporting the concept of surgical de-escalation in those patients. Stage 1A2, 1B1 less than 2 cm, less than 10 mm depth of stromal invasion, or less than 50% depth of stromal invasion on pre-op MRI. But still more randomized trials are needed, especially on the role played by LVSI, high-grade pathology and outcome of less radical surgeries. Thank you.
Yeah, thank you, Roli, for summarizing this concept of less radical surgery for cancer cervix. However, all this assessment, it has to be the patients have to be very carefully selected, and you need a good pathologist, you need good imaging to actually select this patient for a conservative surgery, and also also you need good follow-up. So it's not that you just do the surgery and forget about it. They need to come back for follow-up also, because only then you'll know whether who are the patients who are recurring. So all this, in our country, we still don't know. It has to be in very good centers, and the patient should be willing to come for follow-up. So it's not that she gets operated and goes to the periphery. So it's careful patient selection is very, very important.
Yes, ma'am.
Yeah.
That's very true. And in
Yeah.
fact, surgical procedure must be weighed with radiotherapy treatment. There must be a comparative study side by
Yes.
side for the survival data. And stage wise, you see almost similar result is obtained by radiotherapy also, except fertility preservation. But for that case also, in the earlier cases, we give physiotherapy, which is a radioactive material directly in contact with the cervix only. So the radiation does not go
Needles
inside.
are there.
No, not needles. It's the physiotherapy, booms type thing. They are available. Earlier, they used to be available. Oh, you are online. So this is a very nice presentation. And the only thing is, if there is LVI, we have to be very careful. If the staging must be done very carefully. That's very important because
And
everything.
one more thing is follow up, as ma'am said.
Yes.
With follow-up and good
So that
pathologist is also needed.
Yeah.
follow
Because
में देखते रहो मरीज को और
my
बुलाते
practice is I always ask the patient to come every month for 3 months, then 3 monthly, then 6 monthly. And when I ask them more than 6 months, they just disappear. So if you keep on
doesn't
asking
disappear.
them,
You just write on the paper, follow up, so that you
Yeah.
are not at the error side. You are
and,
always
and
on.
you must prescribe something or the other placebo type of thing or vitamins so that they will know, okay, this has to be taken.
And
So
they'll
that is
come
right.
for
Yes.
follow up.
Don't
Yeah.
say that you are cured. You are all right, but
And many times the patient on follow up also don't tell that they are having spotting after operation. Because
then
just now I'd seen your patient few days back and she was having at the fornix a spot of
yeah,
thing
that has to be checked.
that
Every
needed to undergo again an examination, a PAPS or a culture, something like that. Sunny, we are
gradually,
online.
gradually the things will improve. Pathological examination and imaging that will improve, and we will also be in the line of Western countries.
Acha Roli, one more thing you tell me, what should be advised to a pregnant lady? Suddenly she comes to know she is having early stage cancer, cervix. Roli,
Yes, ma'am.
uh,
Yes, ma'am.
early stage cancer cervix in a pregnant woman. What should be advised? To continue the pregnancy or to
Ma'am, it depends on the stage of the patient. If it is a micro invasion, we can go for colonization procedure in pregnancy with cervical circular simultaneously. But if we think it's an aggressive type or it is 1B1 with LVSI, then then we have to look for the gestation. If patient is in which trimester, it is second or third trimester. If fetal viability has reached, then definitely we have to go for termination of pregnancy, and then after fetal viability we can go for termination, and then we can proceed for radical hysterectomy. But if the fetal viability has not reached, then we have to discuss the risk and benefit with the patients, and then we can, according to the discussion with the patient, we can proceed further.
No, I didn't get it. Radical hysterectomy for whom? If it is viable, then.
Ma'am, radical hysterectomy, if the fetus has reached viability, and if we can terminate the pregnancy in stage 1B1 till 1B1, we can wait for our pregnancy to continue till fetal viability. And
Okay.
if it is beyond 1B1, then definitely we have to terminate the pregnancy. There is no option of continuing the pregnancy.
Exactly. Because if
So
it
it's
is more than
termination in the sense, termination should be, it's basically by cesarean section, a
cesarean.
classical cesarean section along
Yes.
with a radical hysterectomy.
Termination by classical cesarean section, yes.
Yes, that's right.
Yes. Very nicely presented, very nicely said. Ma'am also very nicely took up the role of Roli.
That's
Chairperson doing this work of
yes.
speaker.
Speech
Thanks, ma'am.
speaker of Dr. Roli.
Thank you.
Chalo, koi baat nahi. I think so. There is
Thank
a
you.
net issue in Gorakhpur.
Yes.
Where Roli is also from
Okay.
Gorakhpur, na? That's why we
Yes.
all are also having many times. It's going
Okay.
blackout. Anyway, chalo, we managed to conduct it properly, complete it, and
Yes.
it was really first time with you, and we felt so nice when ma'am took over everything and gave the presentation on early stage cancer cervix management, and great inputs by all. Yes, are there any questions in the chat box? The team will tell us. Clarinet team? Clarinet people? Hello?
What
अभी
about?
इनका नेट गया. Anyway, I think so most of the questions have been answered and very
Yeah.
well taken up in the presentation itself. In detail and elaborate information was given. It was very nice. You may conclude, Doctor.
Thank you, Dr. Saritha and Dr. Roli and everyone who is attending. Thank you so much. I think this is very important topic, and now the cervical incidence.
We lost connectivity.
Yeah. Anyway, let us conclude. Thank you,
Yes.
ma'am. Thank you,
Thank you.
Roli. And
Thank you
thank
so
you, the
much.
Clarinet
Thank you so much,
team.
ma'am.
We'll call you again, once more. Let's see you in the next session. Okay. Bye. Good night for now.
Okay. Bye-bye. Bye-bye. Thank you.
Thank you.
So thank you so much, everyone. With all your permission, I'm closing the session over for today. Thank you.